Subsequent to that, I think every decade we have been making some, new change and evolution in the management of Hodgkin's, from MOP to ABVD, and then to the discovery of monoclonal antibodies. Then we have the immune checkpoint inhibitors. In between came the stem cell transplantation, and now maybe the future is for CAR T cell therapies. And I think the other thing which we are going to discuss is the role of ctDNA and the role of genomics, which is evolving, I think, at this point in time. So I think overall, uh, we have made tremendous progress, and the goals of treatment in early stage and depending upon the age, and in elderly people and the stage, the goals are also maybe different. I mean, the early stage, we're talking about cures and reducing the toxicities, whereas in elderly, we're talking about, still wanting the efficacy to be there, but not giving them a lot of side effects. So there are a lot of issues still which are pending in spite of having very, very good outcomes in patients with Hodgkin's disease. So we need to sort of discuss these and have more clarity as to how we should improvise or improve on the existing outcomes of patients with Hodgkin's disease. So I think the whole program is divided into three parts. We're going to be having a lecture from our international guest speaker, followed by two panels. So the first panel will be done by me, and second by Dr. Reena Nayak. So I think not stand between you and the international speaker. So Dr. Martin Hutchings, who is our guest speaker here. I'll just introduce him and invite him to the podium. He's a hemato-oncologist and a senior consultant from Department of Hematology in the Copenhagen University Hospital. He's a professor of hematology at the University of Copenhagen. He's responsible for lymphoma treatment and clinical research, and founded Denmark's only dedicated phase 1 unit of experimental treatment of hematological malignancies. And he's pioneering his work in early development of lymphoma immunotherapy. So after his master's in 2000, he trained in nuclear medicine until pursuing his current specialization in clinical oncology. In 2006, he defended his PhD on PET-CT in Hodgkin's, which has really become so very critical in our day-to-day decisions, especially in the advanced stage. So Dr. Hutchins is an active member of various research groups, including URTC Lymphoma Group, which he chaired from 2013 until 2017. He has several clinical and translational studies in the field of lymphoma, with an emphasis on phase 1 hematology studies and on phase 2 and 3 Hodgkin's lymphoma and mantle cell lymphoma. He has a keen scientific interest in molecular imaging of malignant lymphoma. He's a prolific lecturer, educator, and research supervisor. So I think we're going to be gaining from his talk a lot, because I think from not only from hematology, oncology, from nuclear medicine, from molecular, so he's totally engaged in Hodgkin's. So I invite him to the podium to deliver his talk on Hodgkin's.
So thank you very much for the kind introduction and for the invitation to this meeting, your wonderful country. This is going to work better if I find my slides, so maybe someone will help me doing that. In the meantime, thank you very much for taking us back to the history of, I need the slides, please. Back to the history of Hodgkin lymphoma. I myself did part of the PhD that you mentioned at Guy's and St. Thomas's Hospital in London. And at Guy's Hospital, they have a museum where the 7 specimens are kept in formalin. And a few years ago, they actually did what we so often do in hematology. They did a pathology revision of these 7 specimens. And interestingly, and maybe as a comment to our evolving classification of lymphomas, actually only 4 of the 7 cases had Hodgkin lymphoma. So the remaining 3, I think there was one which was a bit difficult to define. Maybe it was a T-cell lymphoma, and there were 2 cases with TB. So it just goes to show that what we think we know yesterday will be something that we didn't really know tomorrow. And I think that is also to some extent true when we talk about the management of Hodgkin lymphoma. But I completely agree with you that it's a balance between toxicity and efficacy, and we have come a super long way when it comes to efficacy. And in the last couple of decades, we've focused a little bit more on toxicity and making treatment a little bit less toxic for particularly our young patients. So these are my disclosures, some of which are relevant to the content of this talk and the following discussions. I run a phase 1 unit, like you said, for hematological malignancies, mainly pharma-sponsored studies. So that explains why we have so much research support from the industry. This is a disclaimer slide. You don't necessarily have to read all of it, but what it tells you is that the views expressed in the following 30 minutes are the views of myself and not Takeda, which is the sponsor of this evening. So I'll begin talking a little bit about newly diagnosed disease, what we also call first line treatment. And to cut a very long story quite short, in the last 20 years, which is the 2 decades where I worked with Hodgkin lymphoma, we've had 2 major developments, particularly when we look at advanced stage, but also early stage disease. We've had the introduction of PET and PET response adaptive treatment, and we've seen new agents for the first time in 40 years introduced into the management of this disease. And we can sort of split these 2 decades into 2. The first decade was introduction of PET, and the next most recent decade has been the introduction of novel agents. But many of us are still stuck with the regimens that we have used for much more than 2 decades, BIACOP escalated and ABVD, and no doubt that ABVD is still the gold standard for treatment of this disease in most parts of the world, including my own country, where we don't have access to novel agents in first line, at least not yet. And with the conventional treatments, we have a number of unmet needs or problems that we still need to solve, and certainly that we needed to solve 10, 20 years ago. One of them is efficacy. Even though we are successful in curing the majority of patients, there are still patients who fail with ABVD. It's somewhere in between 25 and 35%. And particularly the elderly patients, the frail patients who cannot tolerate full dose chemotherapy or the more intensive regimens, they have perhaps long-term survival, which is closer to 40 or 50%. The more intensive regimens used quite a lot in Europe. BIACOP escalated is the most important of those. I know it's not used so much in India. They are effective, but they cause increased toxicity, both acute toxicity and also long-term toxicity in the shape of infertility and secondary leukemias and MDS. We have the content of bleomycin. It used to be a big problem, a lot of lung toxicity. All doctors my age who have dealt with lymphoma or older have seen patients die from bleomycin-induced lung toxicity, often patients who otherwise were in remission from the lymphoma, which is of course critical. But also the content of anthracyclines, which is not talked so much about, is a problem. And at some point, we need to reduce the cumulative doses of anthracyclines, because with the vast majority of patients surviving for many decades, I think we have underestimated how much cardiac morbidity there is. Fortunately, in the last 20 years, which are the decades where we have seen most patients cured with anthracycline-based regimens and not mustine-based regimens, these are the 2 decades where our cardiologists have also become very good at treating heart failure. But that doesn't mean that it's a success, that we need patients treated for heart failure for the rest of their lives. And eventually, if you have a heart failure, your expected lifespan will be shorter. So I think that's a very important thing to stress. I believe we underestimate the damage that we do with anthracyclines, at least when we give so large cumulative doses as we do nowadays. Neuropathy, musculoskeletal disease, psychosocial disorders, all are problems that our survivors live with, young as well as old, and they have to be recognized and also dealt with and respected when we design future strategies. But so back to the developments of the last couple of decades. PET was introduced. First, we learned it was improving our staging. Later, we learned that the end of treatment response assessment was more precise with PET than with CT. And we soon found out that an early PET scan during treatment was very effective in identifying patients who responded well and not so well and predicting long-term outcome. And agreeing, most of us at least, 15 years ago that one size doesn't fit all, that some patients are probably better treated with something like Beercop and the majority probably better with ABVD. We started using PET and PET response adaptation of treatment to tailor the treatment into the individual patient's response and characteristics rather than just choosing by geography, which was the case before then. You all are familiar with the results of these big studies. Rathel from the UK, an international study, taught us that we could omit bleomycin after 2 cycles of ABVD in patients with a negative PET scan after 2 cycles. The HD18 study from Germany taught us that if we use Beercop escalated and scan the patients after 2 cycles, if they are PET negative, we can stop treatment after 4 cycles rather than after 6 or 8, which had been the standard, and thereby obliterating most of the risk of secondary leukemias and also greatly reducing the risk of infertility in both male and female patients with no loss of efficacy. And actually also importantly, the French AHL 2011 study also gave patients Beercop, and the randomization told us that if the PET scan is negative after 2 cycles, you can change from Beercop to ABVD without losing efficacy and again maintain fertility in the vast majority of patients. I do that particularly in my young female patients with advanced stage disease. So that's PET response adapted treatment. Then came brentuximab. 12, 13 years ago, we got the results of the phase 2 study of single agent brentuximab vedotin in relapsed refractory disease. We saw that it worked in the majority of patients, very impressive overall and complete response rates, and many of the complete responses being very durable, suggesting a potential cure for some patients. And I believe that was the first time that we saw any hint of cure of Hodgkin lymphoma with a single agent. Not even back in the 50s and 60s, when chemotherapy was first explored, did we see real long-term survival with any single agents. So that was the basis for the introduction of brentuximab vedotin in earlier lines of treatment. And the most recent introduction is the one that I present first, which is in first line. That's how we develop drugs, right? Echelon 1 was a randomized study, including more than 1,300 patients, a global study, directly comparing the standard ABVD versus the experimental BV-AVD, so essentially replacing bleomycin in the experimental arm by brentuximab vedotin in patients with stage 3 or 4 newly diagnosed Hodgkin lymphoma with a modified version of progression-free survival as the primary endpoint. So these were the results of the primary analysis presented now more than 5 years ago. This was the analysis that led to the approval of BV-AVD in first line in many regions, first US, later Europe, and then later other regions of the world. This was based on a difference in modified progression-free survival in favor of the experimental arm by 5 percentage points, absolute points, 77% modified progression-free survival at 2 years in the ABVD arm, which, by the way, is the best performance of ABVD ever seen in any study, interestingly. So it was a good standard arm, versus 82% modified progression-free survival rate at 2 years for the experimental arm. Statistically significant, it was debated whether, in fact, that difference was clinically meaningful. Of course, that would have to be shown in later updated analyses, and therefore, we've been very busy updating the efficacy and safety data from this study annually ever since. We recently published the 7-year analysis, and the big question is, next year, is there going to be an 8-year analysis? Well, probably yes. I'll just linger a little bit on the primary analysis before going to the more recent data. It's important to recognize that things change with time, also rapidly. And if you look to the bottom right side of this slide, you will see a small description of the unstudied deaths occurring during the treatment in this study. And this is quite important because remember the Rathel study told us that we could omit bleomycin in patients responding well. This study had a PET scan after 2 cycles, but it didn't change treatment. That wasn't part of the plan in this study. So patients who were PET negative after 2 cycles of ABVD kept getting bleomycin for the rest of the treatment. And that has been criticized, even though the study was planned prior to the presentation and publication of Rathel. It could have been amended and it was discussed, but it didn't happen. Now, there were 13 deaths, on-study deaths, not due to lymphoma, but during treatment, so presumably caused by treatment in the standard arm, 11 of which could be attributed to side effects of bleomycin. Now, we know from Rathel that not all, but probably the majority of these deaths, which by the way were also modified progression-free survival events, they would have been avoided had the patients been treated according to Rathel. On the other hand, in the experimental arm, there were 9 deaths during the treatment or immediately after, 7 of which were due to complications of neutropenia. We discovered after approximately 70% of the patients had been included in the study that there were too many cases of deep neutropenia and neutropenic sepsis in the experimental arm because BV causes neutropenia more so than bleomycin, of course. Now, at that point, mandatory GCSF prophylaxis was introduced, and after that introduction, there were no more fatal cases of neutropenic sepsis, interestingly. So nowadays, when we give treatment, whether it's ABVD or whether it's BV-ABD, we will, of course, treat patients according to that knowledge. We will give mandatory GCSF if we give BV-ABD, and we will omit bleomycin if we give ABVD, provided the patients are PET negative after 2 cycles. Already 2 years after completion of treatment, we have already changed our treatment in a way that we can't 100% trust the data that we read. Fast forward to last year, this was the 6-year analysis of Echelon 1, and what we saw both after 3, 4, 5, and 6 years was that the PFS difference, not the modified PFS because we stopped recording that, but the investigator-assessed progression-free survival difference in favor of the experimental arm was maintained with time. But more importantly, also overall survival now for the first time was significantly different in favor of the experimental arm. And I think the question mark around the clinical meaningfulness of the difference that many of us had after 2 years with the primary analysis, I think that has been settled with an overall survival difference, because this is a disease where we have a lot of good subsequent treatments. We all rejoice in the fact that we have 2nd and 3rd line treatment that can actually cure patients. I mean, solid tumor oncologists wish they could do that in 2nd and 3rd line. We have been able to do that with Hodgkin for many years. So if you have a 1st line treatment change which causes an overall survival benefit, I think it's a very strong hint that it's clinically meaningful. We also had a 7-year update, like I said, presented at the EHA meeting very recently, and hopefully soon in a paper. And this analysis showed the same PFS and overall survival curves, more or less, as after 6 years. I don't think you're surprised by that. But there were some additional analyses which I found interesting. I hope you'll find them interesting too. First of all, we looked at overall survival, not only by treatment arm, but also by results of PET after 2 cycles. And to me, it was interesting to see that looking at overall survival, the only group of patients who fared significantly worse than the rest were actually those who were PET positive after 2 cycles, not a surprise, but only those who were in the standard ABVD arm, which was a bit of a surprise to me, and I haven't really quite gotten my head around why this is, but it looks quite significant. Another important thing is that the 7-year update included subgroup analyses, both of progression-free and overall survival, and we saw consistent benefit of the experimental arm across all these subgroups, both when looking at progression-free survival and also when looking at overall survival, as shown here. And this is a little bit in opposition to the earlier reports from the primary analysis, where there were some subgroups that looked like they benefited less and more than other subgroups, at least when it came to modified progression-free survival. For example, strange differences in the hazard ratio depending on geographical region, which is always a little bit strange. But that has all been leveled out with time, and that's one other good reason why to do late follow-up updates. Also, we looked at fertility, which is, of course, an important secondary safety endpoint when the majority of patients are young, as in Hodgkin lymphoma, and the expected finding was that we did not see any loss of fertility in patients treated in the experimental arm, neither the female patients treated or the female partners of male patients treated. And of course, we know that ABVD does not reduce fertility, at least not in relatively young patients. So it's comforting to see that not only is the fertility as good in the experimental arm, it actually looks a little bit better. I wouldn't postulate that you can improve fertility by having BV-ABD. I think that would be stretching it a bit too far, but I think the data show clearly that there's no reduction. Secondary malignancies are seen after anthracycline-based chemotherapy. We know that. And after 7 years, we have second malignancies at 5%, a little bit more in the standard than experimental arm. But the imbalance that we've otherwise seen in previous analyses showing almost twice as many second malignancies in the standard compared with the experimental arm, a difference that you couldn't explain from the content of bleomycin and BV, that has also been leveled out. And at least that helps me better understand the data than I did so far. So much for the 6 and 7 year update of Echelon 1. I think it's a pretty well-established study. And I also think that actually we could stop doing the updates now, because I don't think we are likely to learn much more until perhaps in 5, 10, 15 years, where we might be able to see interesting findings when it comes to neuropathy and perhaps cardiac morbidity. But let's see. Another study which came out quite recently. The first data came out last year, and we've had a very interesting update presented at the recent EHA meeting as well, is the German HD21 study, another randomized study comparing conventional and brentuximab vedotin containing chemotherapy in newly diagnosed Hodgkin lymphoma. Now, you should be aware that what I'm showing you now are data that had not led to any approval in any country. So the results of this study are definitely being chewed by regulatory agencies in both North America and Europe, and soon elsewhere, but this is certainly off-label also in India. The HD21 study randomized the respected and feared BRCOP escalated regimen, which had been the standard in Germany for 20 years, against a novel regimen inspired by BRCOP, but very different. The bleomycin and the vincristine of BRCOP escalated has been taken out and replaced by brentuximab vedotin. The etoposide, the cyclophosphamide, and the adriamycin have been kept at the same doses. The prednisolone, 100 milligrams for 2 weeks in each cycle in BRCOP, which is crazy, has been taken out and replaced by 4 days of dexamethasone, much better for the patients. And best of all, the procarbazine, which is a drug that I intensely hate, has been replaced by dacarbazine on day 2 and 3. And this has given us a regimen which is much more tolerable. That has actually been shown in a randomized phase 2 study by the Germans 5-6 years ago. This was the big phase 3 study with the endpoints not of superiority, because BRCOP escalated is hard to beat. It has progression-free survival at 2 years of over 90%. So the endpoints was there were actually 2 primary endpoints. One was safety, a complicated measure of treatment-related morbidity, and then non-inferiority of the BRCAT arm. So the Germans would be happy if this was safer and not any worse than BRCAT. So what did the results show? Well, last year, both endpoints were met. We saw the safety analysis and we saw the non-inferiority analysis last year at the ICML meeting and later repeated at the ASH meeting, and both co-primary endpoints were met. But what about the most recent analysis? Well, first of all, it shows actually superiority, as I'll show you in the next slide. But also we've had recent analyses showing why is safety better. I didn't understand the endpoint because it's a mix of all kinds of different morbidity features. But if you look at the different features that I list up here, it makes a little bit more sense to me. You see the transfusion need, half as much in the BRCAT arm as in the standard arm. Also hospitalizations, much less. Interestingly, not more peripheral neuropathy. Maybe that's because vincristine is even worse than we thought it was. But most interestingly, and these are the bars that you see here, they might be the explanation for the next slide. You see that with the blue bars, which represent BRCOP escalated, you see a very clear drop in dose intensity cycle by cycle. And this is what we all know if we've been given BRCOP escalated. Many patients, they cannot tolerate it. They have deep cytopenias. They are hospitalized. They have grade 3 adverse events. And that means we need to reduce the dose, sometimes even delay. With Brecat, you can see the orange bars, the dose intensity is much better. So when I show you the most recent analysis, which shows not only non-inferiority, but superiority of Brecat, is that because of BV, or is it in fact because Brecat is designed in a way that enables the physicians to keep the dose? I don't know, but we all know that dose intensity in Hodgkin lymphoma is key to cure. I've been treating some patients not only with Brecat, but also with BV-AVD, and I've been treating some patients with both. And I think maybe I'm the only one in the world who has designed a study where patients get both so far. That is the COBRA study, which comes here. Not a randomized study. We presented this at the EHA meeting last month. A phase 2 study where all patients had BV-AVD, PET scan after 1 cycle. If the PET scan was negative, we continued as per echelon 1, full 6 cycles of BV-AVD, and we showed exactly the same 2-year progression-free survival as in echelon 1, around 88%. What we wanted was not to help those patients. They are doing pretty well already. But the PET positive patients, they went to Brecat. Now, in the 3-year update of the echelon 1 study, patients who were in the experimental arm, so they had BV-AVD, who were PET positive after 2 cycles, they had a 3-year progression-free survival of 69%, which is not bad, but in this day and age, it's not good either. So what we wanted was, with Brecat, to raise that bar up to something similar to the PET negative patients. And what we found in the 2-year update, so all patients had been followed for a minimum of 2 years, the 2-year progression-free survival for those patients PET positive after 1 cycle of AAVD who went to Brecat, we had 2-year progression-free survival of 91%. So not only as good as the well-responding patients who were PET negative, but actually a little bit better. Of course, not statistically significant. So we call this a positive study. But it also, as a little side effect, made it possible for someone like me to ask the patients, what do you prefer, BV-AVD or Brecat? Because a good handful had tried both. And they more or less unisonely said, it's more or less the same. And if that had been BRCOP escalated, that is not what they would have told me. They would have been devastated by the chemotherapy. So I'm quite comfortable with Brecat. And of course, this is off-label, so I shouldn't talk too much about it. I'll just go back to one interesting feature from the most recent presentation of data, which is that the well-known feature of BRCOP escalated, which is a reduction of fertility, is much less serious after Brecat. You can see that the FSH normalization is completed in almost 100% of both male and female patients after a couple of years, and that is much less likely after treatment with BRCOP. And also the fertility rate seems to be much better after BRCOP escalated, after Brecat. So now a little bit of salt in the wound, of course, for the company behind brentuximab vedotin is the relatively recent publication of the results of the S1826 study, which was an academic group comparison of BV-AVD and nivolumab-AVD in newly diagnosed advanced stage Hodgkin lymphoma, mainly performed in the US. This is a study which has been only published based on very preliminary data. It was actually not the intention of the investigators to publish this already last year because there was only a median follow-up of just over a year. But the independent data monitoring committee of the study demanded that the results be made public because of a relatively significant benefit, which seemed to be in favor of the nivolumab-containing arm. But again, it's relatively limited follow-up. There will be a publication with a mature analysis probably next month in the New England Journal of Medicine, if I guess correctly. So this study showed like this when it was published at the ICML meeting last year. Very short follow-up, but progression-free survival at 1 year estimated at 94% for the nivolumab-AVD arm and at 86%, which is not bad for the BV-containing BV-AVD arm. Consistent across these subgroups and also others, these are just subgroups that I've selected for you, stage, prognostic factors, and so forth. So that leaves us, and I should also say that nivolumab AVD is not approved anywhere. It is recommended to some extent by the NCCN guidelines, but it's not approved anywhere, and it's not meant for standard use in any countries that I know of anyway. So at this point, we have a relatively complicated slide when we try and overlook the standard and potential treatment options for newly diagnosed patients with Hodgkin lymphoma, some of which do not have reimbursement for any non-conventional chemotherapies, and that makes life a little bit less complicated, at least because we don't have access to novel agents, but hopefully that will change in the near future. Another study that I'd like to mention also, which is completely off-label because this is not approved anywhere in the world as far as I know, is the combination of brentuximab vedotin and bendamustine. Many of us, from when we first got our hands on single-agent brentuximab vedotin, started looking for combinations for patients with relapsed refractory disease. And one of the first ones to be published 10 years ago was actually the combination with bendamustine, which not only is safe, but also without any randomized data to lean on, seems to enhance the efficacy of brentuximab vedotin or bendamustine on their own. So this was the HALO study, which had an update given by Andrea Gallimini also at the recent EHA meeting. And what was the HALO study was a study of that combination in elderly and frail patients found ineligible for normal anthracycline-based combination chemotherapy. And you can see here on the response rates that they are really not as good as ABVD in a young population, but actually on par with what we would expect from something like AVD or CHOP in the elderly and frail population. And this is actually something that I've begun giving to patients who are elderly and frail, or perhaps with cardiac comorbidity, which makes anthracycline use non-advisable. This is also very effective in relapsed refractory disease. I'm not showing you a lot of data there. Of course, it's all off-label, but it's yet something which is really being used by many colleagues across the globe. So moving to second-line treatment, I'll skip the next couple of slides very quickly. Also off-label use, but it's no secret that brentuximab vedotin has been combined in second line with almost all of the many non-cross-resistant gemcitabine and platinum-based induction regimens that we use across the world. I think there are more than 10 of those. They've never been directly compared, and they are probably more or less equally effective. What doesn't change is that the addition of BV seems to enhance the efficacy without significantly adding toxicity and without reducing our ability to harvest stem cells. This was true in the Spanish BRESHAP study, which was ESHAP plus BV. They found overall response rates of 90%, including 70% with complete responses, which is much better than you would expect from the non-BV containing ESHAP. Exactly the same was found in our study from the Hovan and Danish group, the BRAVE study. We used DHAP, so without etoposide, added brentuximab vedotin, got overall response in 90% and complete responses here in 81%, small numbers. I don't think there's any meaningful difference between the two. Brentuximab vedotin in second-line treatment perhaps can be applied in a different way. And this is actually not off-label, this is on-label. These are the patients who do not respond to second-line multi-agent induction chemotherapy. Those patients have a 50% chance of reaching a CR if they then are salvaged with brentuximab vedotin as a single agent prior to transplant. So instead of adding BV to the induction chemotherapy, which is off-label, you can also give your induction chemotherapy in second line. If you do not get to a CR, don't do the transplant, try brentuximab vedotin instead. 50% of the patients will get into that CR that you're looking for in order to make the transplant meaningful. And the long-term outcomes for several of these cohorts where they've actually published long-term data look practically as good as the data you would expect from a patient going straight to CR on initial induction chemotherapy. I'll skip that for sake of time. Again, off-label, even in the US, where they can do almost everything, is the combination of brentuximab vedotin and checkpoint inhibition. And we must admit that even despite our attempts to improve on second-line conventional chemotherapy, the best combination in second-line probably is the combination of BV and Nivo, way out of my reach and the reach of my patients, but the response rates that we see here look better than anything we get from conventional chemotherapy, with CR rates reaching beyond up to towards 90%. And if you look at the survival data for patients treated on this study, however highly selected they might be, as we are so used to from the US studies, they look pretty impressive. Remember, our expected long-term disease-free survival in second line with high-dose chemotherapy and transplant is somewhere in the line of 50, at best 60%. And this is what we get with the combination of BV and Nivo. So it's pretty good, but like I said, out of my reach at least. Another way to improve the outcomes of second-line treatment, of course, is to consolidate, something that we have not used very much in aggressive lymphomas because it has never worked. In Hodgkin, it did work. I was very negative when I saw this study first. I was sure it was not going to work because no attempt at giving consolidation in aggressive lymphomas had worked so far. I don't think actually the company behind the drug, that was Seattle Genetics and Millennium at the time, were particularly interested in this study either, but it was a demand from the European authorities that in order to get approval in relapsed refractory disease, they wanted some randomized evidence to support the benefit of the drug. So they came up with this randomized study for patients with high-risk features going into second-line chemotherapy and transplant would be randomized after completion of transplant to either 16 cycles of brentuximab vedotin or 16 cycles of placebo. And these were the outcomes: a highly significant difference in favor of the BV-containing arm. And actually, particularly if looking at several of the high-risk features, you could identify patients with risk factors, identifying maybe 30 to 40% of patients with benefit in the absolute range of 30 to 40% progression-free survival, which is a huge difference. This was looked at a median follow-up of approximately 5 years, and that plateau between difference between the two arms looks to be maintained, and this, at least in the eyes of this observer, suggests again a curative potential of the single agent. So I think the Athera quite confidently shows us that the single agent given as a consolidation can eradicate microscopic residual disease. There's never been an overall survival difference demonstrated. That might be, at least in part, owed to the fact that patients in the placebo arm were allowed entry upon relapse into a study of single-agent brentuximab vedotin. So in other words, a kind of crossover was allowed, and 60% of the failing patients in the placebo arm used that option. So that would at least take away some of the possibility of showing any clinical meaningfulness in terms of an overall survival difference. But why did we do all this? We did it because we knew that it worked really well as a single agent, and that had been demonstrated in a study which was performed now almost 15 years ago and published in 2011, led to the approval of BV as a single agent in relapsed refractory disease in US in 2011, in Europe in 12, and later on in the rest of the world. And this was the phase 2 study of BV in patients with at least 2 prior lines of treatment, and all patients had to have recent organ function and performance status, but also importantly, they needed to have been treated with high-dose chemotherapy and transplant, which was quite a high bar to set, because the majority of patients failing treatment for Hodgkin lymphoma twice are actually the old and frail patients and not the young ones that we take to high-dose chemotherapy and transplant. I think most of you are familiar with the data of this study. Like I said before, most of the patients responded, in fact, 75%, including 34% with complete responses. And while those responders who had a PR usually failed to maintain that PR for very long, as you can see in the overall progression-free survival curves in this slide, Look at the 34% of patients who reached a CR during treatment after 5 years without treatment, because treatment was given for a total of 48 weeks maximum, 16 cycles. 5 years after the end of treatment, 50% of the patients reaching a CR were still alive and progression-free with no intervening treatment, again, and supported by the results of Athera, suggesting very strongly a curative potential for a single agent. Even though, of course, it's a minority of patients, I think it's a very significant and important minority of patients. I'll skip this for the interest of time. So a few years after the phase 2 study of brentuximab vedotin in relapsed refractory disease, we got the results of the checkpoint inhibitors used in the same treatment setting. The Keynote 087 study looked at pembrolizumab in various cohorts that were different depending on prior BV exposure, prior transplant. And they more or less showed the same results regardless of cohort, and results that were comparable with those of BV in relapsed refractory disease, with response rates around 70% and with complete response rates a little bit lower. But then again, complete response, PET response with checkpoint inhibition is something that we are not quite as confident with as in more conventional chemotherapy, including brentuximab vedotin. Checkmate 205 was the similar study of nivolumab in exactly the same setting. Also, patients were divided into different cohorts depending on prior exposure and prior treatment lines, but the results were the same, of roughly 70% of overall response in mature updates, with complete responses seen in slightly less patients than after brentuximab vedotin. So what is best? Well, we don't really know because we don't have long-term follow-up, but the data that we do have are from the Keynote 204 study, which was published a couple of years ago by John Corvilla and his colleagues. So this was a study sponsored by Merck, which looked at pembrolizumab for up to 35 cycles versus brentuximab vedotin, potentially for up to 35 cycles, never given, in the same group of patients who would have been entered into the phase 2 study of BV or into the Keynote or Checkmate studies. So patients with at least 2 prior lines of treatment for relapsed refractory Hodgkin lymphoma. And you see the difference here. The BV arm did more or less like in the phase 2 study, so long-term progression-free survival for the whole cohort around 30%, and that looked better for the patients treated with pembrolizumab. Of course, the follow-up is relatively short, and one criticism of this study, which I find relevant, is that the 35 cycles of pembrolizumab is, of course, very feasible. 2 years of checkpoint inhibition is quite easy in the majority of patients. 35 cycles of BV is science fiction. It cannot be done. So if you look at the treatment exposure data from this study, the actual treatment duration for patients in the pembro arm was twice as long as in the BV arm, which is fair enough because these are 2 different strategies being compared. But if you look at progression-free survival curves, it's not entirely fair to compare them directly because, of course, half of these patients have been exposed to treatment for twice as long as the other group, which means that during the observational time, they have been exposed to treatment in one arm and not to the other. So in fact, it would be interesting to see some kind of landmark analysis from the stopping of treatment. Of course, that will never be done. So what we have to do instead is to wait for a long-term update from this study and see if that difference between the PFS curves in fact is maintained, or whether with time, with more distance to the stopping of treatment, the curves come more together, as I personally expect. And this is not because Takeda paid for my lunch. Good lunch, by the way. In a very nice place on the street side here in Delhi, traditional North Indian food. So that leads me to my conclusions. I hope that if you didn't know already, I've convinced you that the Echelon-1 study has shown not only a benefit for progression-free survival, but also for overall survival when compared with standard ABVD. It has a little bit a more complicated safety profile than ABVD when in terms of acute toxicity, but importantly, it takes away bleomycin, which at least in my hands makes it very useful for patients that I otherwise would be a little bit weary about giving bleomycin. I've shown you data from the HC21 study, and I stress again that the outcomes of these data have not yet led to the approval of this regimen in any regions. But I will promise you that BRCAD is here to stay, even in the US, which has been very hostile environment for BRCAD escalated, which I totally understand. They have actually begun using BRCAD, and it's also part of the most recent version of the NCCN guidelines. We also get a mention of BRCAD in that context. And this is because it is not only as effective as BRCAD, it's actually more effective, and in the eyes of the physician and in the reports from the patients, it's much, much more tolerable than BRCAD escalated. The SWOG 1826 study showed us, at least in very preliminary data, that nivo-AVD beats the progression-free survival of BV-AVD, and we need to see, of course, mature data, some of which will come in the primary analysis, which is going to be published very, very soon. And of course, it'll be interesting to see if that changes treatment in the regions where pharmaceuticals are introduced quickly, such as in North America. Of course, we need to think about this because a very small difference in PFS without any known difference in overall survival has to be justified also with subsequent lines of treatment. And personally, I would be a little bit nervous about losing the chance of giving checkpoint inhibition in later lines of treatment, but that's a personal idiosyncrasy rather than data-supported view. We will have to see long-term outcomes for patients, not only the responders, but also the failing patients, and see how they do in later lines of treatment, because that might be different. So moving to relapse disease, we know that addition of BV to second-line treatment improves outcomes. I've shown you examples of addition of BV to the induction regimens, which is off-label. I also shown you that you can use BV after failing to get a CR to induction chemotherapy that is on-label, and it's really effective. And I've also shown you how we can use brentuximab vedotin as maintenance therapy on label to also improve outcomes for patients with high risk of a second relapse. I've shown you data from the single agent studies of checkpoint inhibitors and BV in late relapsing disease, and also the Keynote 204 comparing these two strategies in patients with 2 or more relapses of the disease. What I didn't show you, and this was in the interest of time, I haven't shown you what's coming, because there are actually many interesting things under development, a lot of CD30 CAR Ts which have a hard time, but also some new ADCs targeting both CD30 and also CD25 are really quite interesting, and also some novel checkpoint inhibitors going way beyond anti-PD-1, also other supportive checkpoints that look very active in Hodgkin lymphoma. Hodgkin lymphoma remains this model disease for development, not only of chemotherapy, but also of novel strategies, including immunotherapy. And we are fortunate to work with a disease where novel as well as old treatments work as well as they do. So with this, thank you very much, and I look very much forward to questions and to the debates. Can you read that? That's the Indian label for brentuximab vedotin. You need to have very good eyes.
You have a few questions.
BV, you are still doing better. What about patients who are PET negative? Is the long-term overall survival attaining CR at PET2 better with BV versus non-BV arms?
So you're asking in advanced stage disease, I
Advanced,
suppose.
exactly.
Patients who are PET negative after 2 cycles of BV plus AVD. What about them? In the Echelon 1 study?
overall the quality of overall survival that we are going to get if we are getting a CR after BV containing regimes versus ABVT.
Ah, right. So that is actually what we showed in the 7-year analysis with the 4 curves. They represented patients with PET positive versus PET negative response. This was after 2 cycles, but let's extrapolate to the end of treatment results. And then those patients in the experimental and the standard arm. And it looked as though the overall survival was the same for patients who were PET negative in the standard and the experimental arm. A prior update of the data showed slight benefit in favor of the experimental arm, but that update, I think the curves looked the same. The only ones sticking out were the PET positive, early PET positive patients on the ABVD arm. Overall survival is always difficult because it's depending on subsequent treatment lines. So you really need a lot of data to really appreciate and understand the data, but I think these curves are interesting. And to me, they raise an appetite for analyses of the subsequent treatments in these different arms.
Subcontinent. So has any study been done on a cost-effective analysis on an upfront brentuximab usage in stage 3-4 advanced Hodgkin lymphoma? Because these patients are young, in their 20s and 30s, and the parents are also young.
I think a lot of cost-effective analyses have been done, and they've been done differently in many different countries because, of course, reimbursement of a treatment like this depends on some justification.
Data on that, because you spoke that Hodgkin is a child poster for immunotherapy. So I'm a medical oncologist. I say lung is a child poster for immuno-oncology. So we have a data in solid organ. Do you have a data in hematological organ? This disease that cost-effective use brentuximab upfront in stage 3-4 for that delta, which is not that big.
It's an interesting question. So the cost-effectiveness analyses that have been performed have been in comparison with conventional chemotherapy, because of course the combination of BV and AVD came prior to the combinations with Nivo and AVD. So they have not, to my knowledge, been compared when it comes to cost effectiveness. That is probably to come, but the cost effectiveness analyses have been compared with ABVD. And of course, they have been a little bit tricky because we all know ABVD is practically free, right? So most of the cost of ABVD is actually the additional cost of treatment for patients who fail, the transplants, the subsequent treatments with novel agents, the allogeneic transplants, the follow-up, all the cost of healthcare for patients failing treatment. And I think most of these analyses have probably been performed by the companies selling brentuximab vedotin because it's a hard nut to crack to convince payers that they need to increase the cost of a treatment which used to be really cheap by tenfold. But then my argument, and I haven't been part of any of these analyses, have been, what about myeloma? The only reason why we accept paying so much money for extending sometimes a pretty bad survival in a disease like myeloma is because it's been expensive for a very long time, right? Now, Hodgkin lymphoma has been cheap until yesterday, and that's why the rise in cost seems to some unacceptable.
So that German attempt of escalating the protocol when brentuximab was not available, that BCOP, suddenly BCOP was costly because it required febrile neutropenia, sepsis, infusions. So is the concept of escalation gone when brentuximab is there?
So the concept of escalation is, wouldn't say that's done because, the escalated part of BCOP is actually a dose adjustment according to toxicity, just like in dose adjusted epoch. So you start high, in dose adjusted epoch, you start low. In BCOP escalated, you start high, and then depending on depth and duration of cytopenias, you reduce, and there are 5 different dose levels, and these dose levels are actually maintained in BRCAT. So it's not easy to give BRCAT completely. The thing is, they don't have the same depth and duration of the cytopenias, and they are not hospitalized so often. So most of the time, you don't need to go to different dose levels. And that is what I showed with the different, the maintenance of dose intensity in BRCAT versus BCOP escalated. But you're absolutely right. Giving BCOP is not a piece of cake, and it's not cheap either, because you need an ICU and you need a very good collaboration if you give it in private practice with internal medicine or in countries like India and Denmark, where you treat lymphomas in hospitals, which is, I believe, a good idea. Then you need space in your departments because they will come in, and they will come in the middle of the night in sepsis.
Holding your finances for a salvage and a BMT is better, or uh, doing an upfront brentuximab, if your experience, one take.
Yeah, but I mean, I think in young patients, avoiding the need for second line salvage chemotherapy is a goal in itself. And it's not because I don't like, curing patients in later lines of treatment, but if you're a young person, you want to optimize cure. And it's our responsibility to not overtreat too many patients too much. I've had this conversation with Volker Deal many times over the years. And, even Volker Deal, who was such a strong advocate for Birkhoff escalated and believed firmly in private, he had night sweats over what he had done to his young patients. Because with Birkhoff escalated, you overtreat many, many patients. Is it worth it? I don't know. Is it better to give them Brechat? I'm absolutely confident. It's a much, much better treatment. And Birkhoff escalated is dead.
Let's have a big round of applause for Dr. Martin. So I think wonderful lecture and some discussion. And we're going to have this panel on frontline Hodgkin's lymphoma, for which I'll invite Dr. Ankur Bahal to the stage. He's at the Fortis Gurgaon. We have Dr. Anupam Chakrapani, who's come all the way from Kolkata, Apollo, and Dr. Aditya Jindal. He's at the Tata, Chandigarh. Right. So I think Dr. Martin has covered the entire spectrum of Hodgkin's lymphoma from advanced disease perspective in the young age, old age, and patients who are relapsing. So I think we're going to focus on the first line therapy of Hodgkin's lymphoma in this part of the panel. So I think we'll just, this is the disclaimer. So I think just come up with a short case. This is again a 28-year-old female who presented with a 6-week history of cough and some chest discomfort, pruritus, and sweats. She's an active smoker for 10 years. Bilateral cervical and supraclav nodes, left more than right. And the lab reports are here. WBC is 11,000 lymphocytes, 0.4, hemoglobin 9, platelets 140, some hypoalbuminemia. And the patient has left neck node biopsy, which is showing nodular sclerosing, classic Hodgkin's lymphoma. So, Ankur, with this information, what stage would you make without, how do you approach a patient who's got this Hodgkin's disease?
So a good clinical examination, palpating everything, hepatosplenomegaly, and definitely a PET CT scan in this
Right.
era. And the parameters which you have told is actually indicating towards international prognostic scoring. So I have to identify this female, whether this female has a high risk tendency beyond ABVD or just ABVD. So that is in my picture in this era in 2024. Stage it well, diagnose it well, and prognosticate it well. I'll have an answer.
So Dr. Chakrapani, how do you, look at Hodgkin's? Let's forget about this case. I mean, if you have a Hodgkin's disease, so how do you classify when you to decide your first line treatment in terms of favorable, unfavorable, advanced? Because the treatment depends on perhaps those factors.
Yeah, so once we have done the biopsy and complete immunohistochemistry, we have the diagnosis whether we are dealing with classical Hodgkin's lymphoma, what subtype, or NLPHL kind of thing. And after that, we see the scoring, IPSS scoring based on your, this lady albumin is low. And what is the mass size more than 10 centimeters? So like high risk, but early versus advanced with high risk factor or the low risk factors.
So
the-
favorable without
favorable.
high risk factors?
Yes.
Unfavorable with, maybe
So
early
like,
stage or bulky
yeah,
disease, or
early
we have
disease,
advanced
yeah,
stage disease.
early disease without unfavorable, early disease with favorable, and another group is advanced with favorable, advanced with unfavorable.
So
Like
Dr.
that
Aditya, you
we
agree,
approach.
or you have a different
So,
view?
grossly first, early versus advanced.
Yeah.
And in the early, as sir mentioned, favorable versus unfavorable. And in the advanced stage, stage 3 and stage 4, we apply the Hessen-Clever score, which is IPS.
Dr. Martin, you want to, sum it up,
Yeah,
for,
we do the same thing, and I'm happy to hear that you distinguish between favorable and unfavorable in early stage, because I think at least with the treatments that we give, 2 cycles of ABVD and very low dose radiotherapy for the favorable,
Correct.
as opposed to more chemotherapy and less radiotherapy in the
20 grays
unfavorable.
versus 30 grays?
Yeah, 20 gray versus 30 gray. And in unfavorable patients, we actually mostly follow the German HD17, which is 2 cycles of beer cup escalated, where, by the way, I replace carboxine with dacarbazine. And then 2 cycles of ABVD. We do a PET scan. If that PET scan is negative, we have excellent survival with no radiotherapy.
Right.
And the risk factors in early stage, I think the most important one is not the size of the lesion or the sedimentation rate, it's actually the number of regions. So they can only have 2 consecutive regions involved if they are favorable, which means that a radiation field is usually quite small.
Right.
Whereas the unfavorable are typically those with involvement of large parts of the mediastinum, both sides of the neck or the axilla, and you have radiation fields that begin to look like mantle fields, and you have to give 30 gray.
30.
And this is really what we want to avoid. I don't think it's very important to improve on the treatment of early favorable, to be honest. 2 cycles of ABVD, 20 gray. Of
Right.
course, it can be improved.
Maybe another cycle if it is PET negative.
Traveling around the world and reading the newspapers, I think we have bigger problems in the world than early favorable Hodgkin lymphoma.
So 2 things in my mind. She is female, 28, fertility and smoking status. Very common and prevalent, like upcoming in female smokers, young patients, and whether she has completed her family or not. That will be this is most
Yeah, we'll
common
come to
question
that,
with
yeah,
females.
yeah.
Can I just make one comment? The IPS, of course, we record it as well. I personally do not use it so much. In the treatment choice, we're back now in the real world. I don't have access to BV or Nivo or anything in first line. It's ABVD or beer cup DAC. And when I choose between ABVD and beer cup DAC in advanced stage disease, it's much less based on IPS, and it's much more based on the individual patient characteristics and preferences, including age, including fertility wish, and including also sometimes the need for speed. A young man who needs to have this over with very quickly,
Right.
beer cup DAC can be finished in 10, 11 weeks. That also can be of importance.
So I think it's important to, categorize your patient, whether it is early favorable, early unfavorable, or you're looking at advanced disease, because, that dictates your treatment and the dose of radiation in these patients. So this patient, coming back to this patient, she has bone involvement, as you can see here. She has splenomegaly, and the IPS is 4. So I think that is the moot question here as to, in this patient who has stage 4 disease, what regimen are we going to, look at in this? Dr. Chakrapani, please. So in your day-to-day practice, and after listening to maybe Dr. Martin, what do you think? Are you going to be changing your thought process, or you're going to stick to the old regimens?
In my regular practice, I start with ABVD for sure, for 2 cycles, then PET scan, and then I take a call based on the PET negativity.
So you follow the lateral,
Yeah.
that you give the
So
2
in my-
cycles of ABVD and then take a call on the subsequent therapy depending upon the dual
Yeah,
scoring.
we will score at after 2 cycles of it.
Dr. Aditya?
Same, sir. ABVD is something that I prefer for advanced stage Hodgkin's lymphoma frontline treatment.
Ankur, you are in,
Convince them that it is curable, convince them for ABVD, once the patient is convinced and start taking patient, then I add on that what else can be added. And probably after one cycle, I will say that brentuximab gives an overall survival benefit, particularly in your stage, so that the patient convinced to take at least ABVD. If I upfront in my practice, if I start talking about brentuximab on day one, I see a fallout in practice. Fallout in patient understanding that ABVD, they concentrate on brentuximab, the finances behind brentuximab, and they tend to forget the importance of ABVD. So this is
If
important.
finances are not a constraint,
If finances, then straight away I go with the data of brentuximab
so
upfront.
BV, AVD.
Yes, and
that
in
is-
stage 4 and the young patient and high IPS.
Dr. Chakrapani, finance is not a constraint.
Then based on SWOG, I may go for Nivo AVD.
Okay, so, but that's not approved as yet in any of the, guidelines. Particularly in a young individual like 24, 25 years. Aditya?
So high IPS, I am treating one patient who is a MBBS undergrad student, and we are treating with BV as first line. This
Okay.
chap has extensive extranodal disease at baseline with high IPS.
So any experience with escalated BIOCOP or, in this kind of a scenario where you have extensive disease with maybe, visceral involvement like lung, liver, etc. So have you used, escalated BIOCOP?
Yes, we have both ways. In such advanced patient, we have to use BCOP first and then ABVD, and ABVD first and then BCOP. Like I'm talking about 2013 or 15, 16, when this German protocol came, and we used to de-escalate or escalate depending upon the first PET scan. After
Right,
two cycles,
two
the
cycles.
response, the Dowell score after 2 months of therapy.
No, sir, I'll share my experience, but I have used in 2 patients this approach, ABVD 2 cycle, PET positive, brentuximab not affordability, go for BCOP. It doesn't work. Yeah, as
It hasn't
as per
worked
my
in your
understanding, doesn't work.
Okay.
If you have to go brentuximab based some kind of therapy.
So you like to go upfront BIOCOP?
No. So ABVD 2 cycle, if PET positive, escalate by giving BIOCOP.
By BIOCOP.
Yeah, I have tried in 2 patients, not a good result.
Right.
I have never treated anyone with escalated BCOP in frontline setting. We had few patients where after PET2 with Duvel 4, we have given 2 to 4 cycles of escalated BCOP. And I would say it was not a good experience, especially since I have worked in a government hospital, there was a lot of toxicity. We had to switch the patient.
Anybody in the house wants to share an experience with escalated BIOCOP or BV-AVD in first line in a young patient who has, stage 3, stage 4 disease?
Was in the interim PET was Devil was 4, so I escalated to BCOP for 4 cycles, and after the final PET was there complete excellent response to therapy. But somehow I did the PET again right now, and it's in Devil 4 right now, residual disease. Maybe I have to not recognize.
After, of course, doing a biopsy. Right. Right. So you'll have to do a biopsy to confirm the nature of the, the lesion which you're seeing.
Can I make a short comment?
Yeah.
Just a short comment. I think what the important thing is really that you use PET wisely. So regardless of whether you like BIOCOP escalated or not, or if you prefer ABVD or you have access to novel agents, PET response adaptive treatment was a major step forward. And one thing that I didn't particularly like about Echelon 1 was the fact that PET2 wasn't used. I realized you can't do that in a direct comparison of drugs. So maybe it had to be done. HD21 is actually a PET response adaptive study. They took the PET response adaptation from HD18 and made it part of the HD21 regimen, both for the BV containing and the non-BV containing arm. And this was quite a bet from the Germans, because what if the PET positive rate had been twice as high in one arm compared with the other? Then the comparison would have been very difficult to interpret. Fortunately, it was more or less the same. So this was a clean comparison, and it didn't throw out the baby, which I call PET response adaptive treatment with the bathwater. Echelon 1 tried to do that for a while, but I don't think Echelon 1 wanted to do that, and I don't think they've done it.
So Echelon 1 was not PET adapted.
It wasn't,
It was.
but I still think that there is a strong support for PET response adaptive treatment, and I think there is a strong word to be said for it. And what I hope is that when, with time, we get more and more access to novel agents, we will still keep the PET response adaptive treatment, and maybe we will still in 5 years be discussing whether to give BV-AVD or Nivo-AVD or BRCAT. The important thing is that we still individualize for our patients.
Dr. Lee.
So I have used a little bit of brentuximab upfront for stage 3-4 and another case which I will show in the next presentation. I want to know from your experience, or I don't know if you say you haven't used it, but I will still ask you about your experience with brentuximab. Going through 12 doses continuously with AVD is not easy, even for the young patients. The painful peripheral neuropathy is quite a toxic phenomenon in these patients. And actually completing all 12 cycles or all 12 doses is quite tough. And so is there any suggestion, or at least there was a small paper which suggested that even if we give less than 12 doses, which is something more than 8, the outcomes are not different. So something to suggest that lesser brentuximab may be okay in these patients, considering that it is a new regimen, it's an expensive regimen, and we are dealing with young patients of stage 3 and 4.
It's a great question. Many people have proposed something like RAFL just with brentuximab instead of bleomycin. I think one important difference is that with RAFL, there was a very justified wish to get rid of bleomycin because it harmed the patient and caused death. In this case, the wish to get rid of brentuximab vedotin is mainly financial. Of course, neuropathy is a problem, but it doesn't kill patients, and it can be easily managed with reduction of doses, which is not the case with bleomycin. When the problem is there, sometimes you're caught. It's too late, right? So I can tell you what I do to get patients, the young as well as old, through 12 administrations of BV. I do not entirely follow the label, where there are good instructions for dose reductions and delays of BV. And the typical advice is to go unchanged until you have a neuropathy of grade 2. Then you pause, and then you reinstall BV when the neuropathy is grade 1 or better. What I do, if you have a grade 1 neuropathy early during treatment, I already reduce the dose then without delaying the treatment. Because in my experience, and this is from many patients treated both on the Echelon 1 and later on the COBRA study, and a few patients that I've been allowed to give it off trial, if you have a PN of grade 1 during the first 6-8 weeks of treatment, you will eventually develop into a grade 2. And grade 2 neuropathy is not very fun. And there is a small risk that it stays with the patients for a long time or perhaps permanently. So my advice, which is off-label, I guess, is to reduce the dose to 0.9 already at grade 1 neuropathy, if that occurs early during treatment. And how early, I don't know.
Can I ask one more?
Yeah.
This is a little practical. The upper limit of the dose is kind of 180 for brentuximab. We normally don't give more than that. If you have a very obese patient, how will you calculate the doses, by ideal weight or otherwise? And I'll tell you why I'm coming to this point.
Good question.
So this very obese patient, we did cap it at 180. And eventually, in about 2 weeks' time, he came with a lot of fatigue. He is a diabetic as it is. And he came with ketoacidosis, and it has taken us about 5 days of continuous infusion of insulin to bring down his sugars. And it was kind of, finally, you have to put them into the intensive care. So how often have you seen this very resistant insulin resistant kind of diabetes in patients who have been given these doses, especially if they're diabetic?
I've seen it in one patient, which is much along with your description. And actually, we had the patient in the ICU as well. So I've seen it in one patient, not particularly obese, but diabetic patient. So, a little bit fat, but not really obese. But with the first part of your question, which is about dosing of patients outside, the normal range of BMI, you're opening a Pandora's box, because I've spent most of my time doing phase 1 studies. And, dose finding is really, I mean, if people in this room knew how messy dose finding is, they would be disillusioned. And for very tall or very short or very fat or very thin patients, the dose findings that we have from phase 1 studies do not apply. And there is a lot of things buried in the PK analyses from phase 1 studies that we ought to take into our phase 2 and 3 protocols. But instead, we choose to give drugs by weight or by meter square, and we probably end up with very, very different areas under the curve, both in plasma, but more importantly in tissue.
Right. So I think few questions answered here. And since we're on the bleomycin toxicity, we can have some, thoughts from the panelists here as to what they have seen, who are the patients who are at high risk of developing lung toxicity. Dr. Aditya, I mean, some of these pictures are mentioned here. So you have any experience with bleomycin toxicity?
So during my training at PGI Chandigarh and during my short stay after that, we had seen 5 or 6 patients with bleomycin toxicity. In third or fourth cycle, 3 out of them were elderly, and 2 had history of heavy smoking in the past. So smoking, heavy smoking history and elderly age group, they are at high risk, and we have always been told that GCSF should be avoided in these patients, because that
So did they recover or?
So one patient had early detection and other passed away.
Just embarrassing mortalities. Or 8 and 9 ABVD, DLCO dipping down, breathlessness, CT scan and intubation, ventilator, and fibrosis. So daycare and nursing practitioners should be tuned at whatever is the TLC count. Do not administer routinely GCSF, which they merge with the solid organ and give it active smoking and GFR, all those things, particularly in elderly patient, as ma'am said. That patient is very prone for bleomycin toxicity as well. So that diabetic ketoacidosis. So
yeah, so it's an issue, 1 in 10. I mean, as they say. Dr. Chakrapani, your thoughts?
I've not witnessed such a bad case till now of bleomycin.
Is it?
Yeah, I have not witnessed.
Yeah.
Accountable for this pulmonary toxicity, because I have seen several times I have used GCSF and nothing happens
Nothing
actually.
has happened in your.
I have a comment to that.
Yeah.
So first of all, the risk smoking.
Yeah, smoking is one thing apart.
I'll get to the question. Smoking history and actually pulmonary status is not a particular strong risk factor for bleomycin toxicity. The main risk factors are age and renal insufficiency. The problem is, if you have a poor pulmonary status, including being a heavy smoker, and you get the problem, then you die from it, more likely than if you have fresh lungs. So I wouldn't call it a risk factor. It's a risk factor if you have the problem. It's not a prognostic factor for getting the problem. Second, with GCSF, I do not believe, and I have a little bit of data to support what I think, I do not believe that GCSF itself increases the risk of bleomycin toxicity. What you should avoid is a very high neutrophil concentration in the interstitium. So I believe the main problem, if you want to combine bleomycin with GCSF, is to not give 6 milligrams of pegulated filgrastim on day 4, as we otherwise would, because we all know what happens with ABVD. They come back for the next treatment and they have a leukocyte count of 35. And if they have that in serum or plasma, they probably have a lot of neutrophils in the pulmonary interstitium as well. So I recommend, if you must give bleomycin and if you must give GCSF, give 3 days of 30 million units of unpegulated filgrastim on day 5, 6, and 7. The patient will come back for the next treatment without having that overshoot, and I believe that will reduce at least the problem. Having said that, I haven't seen a single fatal case of bleomycin-induced toxicity in the last 10 years, and I'm old enough to have killed at least 3 or 4 patients with bleomycin.
No, we have more, I think.
So-
Ankur?
Sir, third cycle ABVD, TLC is 2.0 and absolute neutrophil is 400. Very often we see with ABVD. Will you delay or give GCSF? Or you will administer ABVD? Patient is non-toxic, no febrile, no evidence of clinical neutropenia or fever.
No, sir, my in clinical practice, I say, generally, once you give the chemotherapy, count doesn't drop within 2, 3 days. So what my practice, I give these patients, suppose they are dropping day 8. Suppose today ABVD, 8th day you take 1 dose of GCSF.
Right.
Day 15, you are ready for the next
The
cycle.
simple GSF, not
Yeah,
the pegylated.
plain, sir.
But you
And
could-
second thing, sir, many a times like interim PET after 2 cycles, if you have a good nuclear medicine colleague, they can tell you the early signs of pulmonary toxicity in the lung due to bleomycin. Then safely you can,
The HRCT cuts and PET CT scan is very important.
sometimes this gives early indications.
But the neutrophil count after ABVD should not be respected too much. There was
Not
an-
be a deterrent for.
There was
you
a
know,
nice
continuing
UK study. The problem is if you measure the neutrophils, you can't avoid looking at them. And sometimes if you look at them, you get a little bit scared. But there was a nice UK study blinding physicians to the results of the differential count.
So I think this is the
Even-
only indication
And
where
that
it's
study, sorry, I'll
total
just-
count
I'll-
of, 2,000,
I'll just,
2,500, I mean,
just finish.
ANCs of maybe less
Sorry,
than 1,000, you can continue with ABV.
I'll just finish. So the study showed actually not only was there no increased risk of neutropenic infections in those patients who were treated blindly to the results of the differential count, actually the outcomes were a little bit better because they kept their dose intensity. So don't worry too much about the neutrophils.
I have a disagreement here. Giving GCSF increases interleukin-6 and it causes inflammation in the lung. We've seen that in engraftment period. So it causes some release of the interleukins, which are harmful, and bleomycin is given. So GCSF and bleomycin toxic.
I think the NCCN guideline, it clearly says ABPD should be given irrespective of the ANC count. It is clearly said. So if the patient is having no fever, nothing, so no need to give GCSF with ABPD. It clearly says. Why to go for GCSF?
Yeah, the only thing is when you've seen the count less, which is what we just discussed, there is uncertainty and you tend to give. So what we do is if the count is less on day, let's say 14, the first cycle, invariably you delay by 3 days when you give. I give only a single shot of Nukind, but I do it just 1 or 2 days prior to the next dose due. And the count coming back is reassuring that the marrow is sufficiently well. And with that, we maintain the dose intensity also and take away the fear from ourselves and the patient's family that the count was low and you've given the drug. Because eventually, if they come back 3 days later with a fever, then they may question you in that aspect. So.
Right. So I think we've covered a few points, but we don't have time to go into, further details. But before we close this panel, comments from the panelists on the overall survival curves, with the Echelon-1 study. Are you convinced on the, the data, and tomorrow going back, on Monday, you will like to, give ABVD instead of ABVD, the light of, the toxicity and the overall survival data here? Aditya?
Sir, I'm glad Dr. Martin had touched that aspect, the deaths in 2 arms, ABVD versus BVAVD. So the bleomycin related deaths could have been avoided, as you mentioned, if we could have followed the Rethel approach. But if you look at the deaths because of the second cancers, they were also like there was an imbalance, and the difference in AML MDH incidence was not different between the 2 arms. So is it by chance, or do you feel that in real world it will replicate the similar OS difference? Second, it's a kind of amateur question, I would say. After having this much discussion, if we look at the 2 treatment paradigms, ABVD PET2 followed by escalation to something like Brecard, or BVAVD PET2 and de-escalation, which one do you think is going to be adopted?
Yeah, the one that is supported by data, and none of them are so far. But it's a good question. Could we keep the slide on a little bit, please? So what you're showing here is in fact from the 6-year update of the safety, and you're absolutely right. There was an imbalance caused by a different number of heme second malignancies, the majority of which were non-Hodgkin lymphomas. And what happened between the 6-year and the 7-year update was that this difference almost leveled out. So it was at 7 years, it was 5.0 versus 5.9% because of a few cases of second malignancies in the BVAVD arm. And it basically just tells us that small numbers are dangerous. I don't think there's any difference. And you look at what we know about bleomycin. Has bleomycin ever been suspected? It has a lot of problems. Secondary leukemias is not one of them.
Take the data. How many of these patients receive some form of radiation before? So that is more important cause of a secondary rather than the treatment of with the drugs.
But that was almost zero, and it was balanced between the two arms. So sometimes it's just chance. I mean, when we're down to, we're talking about 20, 25 patients in each arm.
So I think this could be the final point in this panel, that the use of GCSF in baby AVD is mandatory because of the risk of neutropenia grade 3 and febrile neutropenia. So I think if you are contemplating baby AVD, you have to have GCSF incorporated in your patient.
And actually, if I may add, just like with the difference that I showed between Breckhead and Bierkop, maintaining dose intensity because of less toxicity, the same was the case if you looked at in echelon 1, after the introduction of mandatory GCSF prophylaxis, you had the expected improvement of neuropathy, of neutropenia and hospitalizations and all the things we'd like to avoid. But you actually also had an improved dose intensity, which is important as well.
Right. So I think we do have a protocol which is better in terms of PFS, OS as compared to ABVD, which can be used in stage 3 and stage 4, especially in younger individuals under the age of 60 years, in conjunction with GCSF. So I think there are any more questions regarding this we can have with the panel. Otherwise, we can go to the second panel. So I think thank you very much for this first panel discussion. Thanks to Ankur and Dr. Chakrapani and Dr. Aditya. So Dr. Martin will stay on. So we request Dr. Reena Nair. She's come all the way from Kolkata. She is the Chief of Medical Oncology at Tata Memorial Center. And she's going to conduct the panel on relapsed refractory Hodgkin's lymphoma. Can I invite the panelists? Yeah. I think Dr. Shishir Seth is here. So he'll be joining us in 5 minutes. Dr. Riaz Ahmed is from Max Saket. Dr. Rahul Nathani from Paris. And we have Dr. Sanjeev and Dr. Gaurav Dixit. So over to you, Dr. Reena.
So yes, Hodgkin's disease remains our most favorite disease from, I think, the time we join MBBS. The first malignancy that we learn about, the first cures that we see in our lives. And for some time now, we can even cure those who have relapsed refractory disease. And if we look at some of the slides over here, just as an introduction, when we give salvage chemotherapies, we have seen that the response rates have been somewhere, or the complete response rates have been somewhere between 20, 30, maximum 40%. With the upcoming of these new drugs, suddenly we are beginning to see PET negativity in almost 70, 80% of the patients. And when we look at the survival curves, they are more horizontal than they have ever been. And there are some curves which are almost above 90% in patients who have relapsed diseases. And this is, hard to digest. But even if there are small phase 2 trials, we can see that there are so many horizontal curves with the checkpoint inhibitors. So coming to the first case that I thought, again, another 28-year-old girl, she presented to us with waxing and waning of lymph nodes for about 18 months in the neck. She then had more recent onset of cough, which was not associated with dyspnea for about 2 months. And she was a little obese. And so she had intentionally or voluntarily tried to reduce weight, but then she had lost 30 kilos over this 2-year period. And that was quite a bit. When we investigated her, of course, she had neck nodes, but her PET scan showed a really large mediastinal mass, which was to the tune of 17.5 into 13 into 12. And I'd like you to remember this value. And she also had other nodes, but they were all above the diaphragm with moderate pleural effusion. The diagnosis was classical Hodgkin's lymphoma without doubting. And so it was a stage 2BX, despite the fact that there was mild pericardial effusion. I know this is not for first line therapy, but any thoughts on first line therapy, or we continue as we had decided ABVD versus, as some people may think a patient like this needs BECOP? Anyone can take. I'm not going to ask by names, but anyone can take the question.
So not BACOP, but here probably I would want to use brentuximab upfront, the bulky mediastinal mass.
It
we
was
know
really
that-
bulky and she was really young. Anybody
We know
else
that,
with-
in a salvage situations, bulky disease is one of the poor prognostic markers, that if they relapse and they had originally bulky disease, their salvage rates are really good. This is where I would want to increase the chances of cure at first level itself.
So I have somebody who agrees with me. Yeah, that's exactly what was my thought when this girl came for treatment. And so I thought instead of taking chance with ABVD, and we've all discussed that escalated BACOP and escalating after 2 cycles, we've all had not very happy experiences. I thought I will start brentuximab with AVD in this patient, and considering that such a bulky disease actually becomes advanced stage. So even though she was not stage 3 or 4, we did decide to go ahead. We had the same problem in interpreting PET. So at the end of the second cycle, she showed what was a partial response. The SUV had come down and the size had also come down. We thought we'll continue with AVD without making any changes and then repeat the PET after 4 cycles of therapy. And here it appeared that the SUVs were stable and the size was also stable. So now we have a stable disease at the end of 4 cycles. We have these real problems in interpreting PET in patients who are taking checkpoint inhibitors and brentuximab. So Martin, if you'll just give us some idea of how to go about it. I know you've already shown the data, and if these patients actually go into response eventually, they do just as well, even though they have been PET positive after 2 cycles. But would you make any changes over here or continue the
So
same?
there are two, this is a good question and a difficult one, and it's a typical MDT situation, right?
Yeah.
So there are two things to it. First of all, can we trust the PET response in treatment with checkpoint inhibitor or with BV as well as with conventional chemotherapy? And the other one is the big mediastinal mass. What do we make of a little bit of PET positivity? Because we know there's a lot of inflammation going on in a shrinking lymphoma. So the first one, I have never seen data supporting looking at PET any differently in the context of BV containing therapy than in conventional chemotherapy. And I haven't seen convincing data supporting looking differently at PET in checkpoint containing therapy either. And I do firmly believe that the concept or the problem with pseudoprogression is totally overestimated. And it's mainly seen in solid tumors. In Hodgkin lymphoma, we very rarely see it. And the main way to avoid that problem is to not scan the patient too early, because then you don't have to worry about it. So in this case, I would respect PET scan. On the other hand, I would be a little bit cautious about a Deauville 4 just over liver background in such a large mediastinal mass, because there has to be a little bit of inflammation. I mean, I can guess that it doesn't go so well because we're talking about relapsed refractory disease, and I'm not that stupid. But actually, at this point, if I didn't know any better, then I would actually be fine and continue with the treatment.
So yeah, anybody would like to continue the same after the 4th cycle? Would you like to rebiopsy at this stage? Would you like to escalate?
we would actually, so after two it was there, and after two more cycles, the same brentuximab is a costly medicine. I'm probably going to rebiopsy and see what I'm dealing with.
But you don't have any data to support doing the scan
Biopsy.
after 4
Yeah.
or basing your treatment on the scan. So I think it's difficult. If you go by the data, ignore the scan after 4, look at echelon 1 and continue until 6 cycles. But now you've done it, you have a problem.
No, this is just a question because eventually I'll show what I have done, but I didn't want fingers raised at that time. Okay, so we did, kind of discuss with the radiotherapy also at that time whether they'll consider after 6 cycles whether we should continue or we should actually think in terms of rebiopsy and escalate at this time. And they, of course, felt that radiotherapy is out for such a big disease in such a young patient. But nevertheless, we continued. And this is what happened after 6 cycles, exactly as you had predicted. This patient again had neck nodes. The size remained the same, and the SUVs increased in that area, and now it was duals 5. We did an excision biopsy from the cervical node, not from the mediastinal, because it was very large. And to do, directed biopsy from there was something which was concerning the radiologists. And so we thought the SUV in the cervical node was exactly the same as that in the mediastinal node. And all that we saw was florid reactive follicular hyperplasia. So this is what it was. We had multiple sessions, multiple discussions with our pathologists, and they said, no, whatever is the CD30 is immunoblasts, and it is not the Hodgkin's lymphoma cells. So we took their word for it. Going forward, was it wise to do a neck node biopsy and actually see what it reflects or whether it reflects the same disease as the mediastinal? That is one thing. The second, of course, we thought that since this patient's biopsy is negative, we will keep her under close observation, looking at ESR for certain, doing a PET scan in surveillance after 3 months, and then considering a VATS procedure in case the duals is still high and we consider a core biopsy from that area. So would it be okay to consider that we had gone ahead with the neck node biopsy and extrapolated it to think that the mediastinal mass with the same SUV would be the same?
I think that was the most reasonable option, and everybody would have done the same thing. Secondly, I would like to wait for another couple of months and do a repeat PET and see what is happening and then take it from there.
Okay, so what I think I missed showing you in the PET. No, this is fine.
If SU was D5, UL is 5, and we are thinking inflammation in the large mediastinal mass, the biopsy from the mediastinal mass showing follicular hyperplasia would have been more expected rather than in a small node showing follicular hyperplasia. Then I have to think that is,
Yeah, the multiple discussions were whether we will really hit the area.
thus,
Most
yes,
of this large mass is going to be inflammation. And of course, it
inflammation
was
at a
a
single
risky,
node is little bit, is.
okay, so you are convincing me that it was okay. Because I've always felt that, maybe I missed at this point of time. So then the decision was if she remains stable, we watch her. If we see there is progression at any time, of course, we will consider for salvage therapy and a high dose chemotherapy. She came back 3 months later for her PET scan. And at that time, she had low backache. And this is the next PET scan that we did. Mass remains more or less the same. But we begin to see a lot of marrow disease and also multiple lytic lesions in various levels of the spine. She, of course, was labeled progressive disease on the PET scan without a doubt. We now went ahead with a mediastinal biopsy from the avid lesion, and this again came as reactive and it did not show evidence of disease. We again did extrapolating. We thought the marrow is involved as well as the bones are involved. So we went ahead with the bone marrow aspiration and biopsy, which showed no evidence of disease. And we actually did not do a biopsy from the lytic lesion. So again, we had no evidence of disease on the pathology that we had, but the scan was definitely progressive. And these are the 4 biopsies from the mediastinal mass, which again did not show the Hodgkin's lymphoma cells. And so it was keeping her under observation for another 3 months and repeating a PET scan. But here very clearly in the vertebra, you can see that there are deposits, and we have done the bone marrow aspirate and biopsy. Again, the marrow was avid on the PET scan. 6 months post therapy, she was asymptomatic. Again, we did a PET scan. Now the mass remains the same, the SUVs remain the same, and the skeletal lesions also seem to have come down. So again, you're kind of wondering whether this is inflammation or what is actually happening to this patient. And this is the kind of CT scan. By this time, the mediastinal mass is almost not seen anymore. We reviewed her when she came back for the next PET scan, which is now about almost a year from the time we have finished treatment. There was a sacral lesion, and this sacral lesion, of course, shows Hodgkin's lymphoma. So now I don't know whether to call it primary chemo-refractory disease or it is a relapse disease, but we are dealing with a pretty resistant disease. And we always had this doubt in mind that we were dealing with somebody who's going to get this disease back. So what would be the preferred salvage regimen for this patient now? She's received brentuximab. She's taken all 12 cycles of brentuximab upfront. She has about a year post her end of treatment, but more or less the inkling was always that she's harboring disease somewhere. So it's not as if she is 1 year post therapy and we can use a similar salvage. So I've put in many questions. All of you can take whichever question you want and answer. So what are your preferred salvage therapy options for a patient who is refractory in this case? Having given her brentuximab, and now that brentuximab is used in the front line, what is your opinion about retreatment with brentuximab in this patient? Would you prefer checkpoint inhibitors instead? In what patient profile would you prefer brentuximab-based therapy, and for whom would you give the checkpoint inhibitors? Then whether there are any drawbacks, advantages, or disadvantages of managing patients with a combination of this in this particular patient. And of course, like we've seen combining these two also gives excellent results. So maybe one by one, everyone can pick up questions. The first is just whichever salvage regimen you think you would like to.
In this case, I will like to use Nivo Ice as a salvage regimen for this patient. Uh, I'm not sure about reusing brentuximab because patient is progressive on brentuximab based treatment. Combining brentuximab with checkpoint inhibitors is not a cost effective approach for our subset of patients.
I think using single agent brentuximab would be difficult. So I would like to add on nivolumab as my first preference. Then second would be pembrolizumab, Keytruda alone, single agent. Then if cost is a major concern, then I can consider salvage chemo with ICE or rehab also.
Yeah, for most of our patients, 75% would get just chemotherapy as salvage, but yeah, there are some patients who can afford. And this was a young patient, and we didn't have to worry too much about costs over here, at least not so far. Anybody who differs with this, so it's Nivo Ice from what I can make out.
So it could be Nivo Ice, could be Nivo plus Pembro, depending upon the cost. But the broad idea is to bring some kind of remission and take this patient for auto transplant because that's the only chance of your young patient. So the transplant is important here. So whichever way I can get remission, I can go Nivo Ice, I can get Nivo GDP, I could go Pembro plus combination, I can go Nivo plus Pembro. We have data for all the regimes working very well in these situations. We don't know which one will hit this disease. But would I use brentuximab again in this patient? Probably not.
So that at least we agree upon.
I agree that the prior exposure to brentuximab probably doesn't prohibit, but it talks against using it again. Not so much because of the primary refractoriness of the disease, more because of the number of cycles given. And in the absence of BV Nivo, which could be attractive, I would also go for a checkpoint inhibitor together with induction chemotherapy. In my country, that would be off-label, so I would have to convince someone that it was a good idea, but I would probably succeed, and that's what we would do. The reason why I take the microphone is to tell you about a study that we're running right now together with the Hoban Group in Holland. So we're giving not ICE, but GDP, but same, together with a checkpoint inhibitor in second line. And we do a PET scan after 4 cycles. We do one after 2 as well. But also the one after 4 determines what happens to the patient. If the patient is PET negative, they continue with the checkpoint inhibitor until a year without high-dose chemotherapy and transplant. If they are PET positive, they go off study.
Even if they're young patients,
So in other words, we're trying to get rid of transplant in second line with this kind of treatment.
okay, even for young patients?
Would this approach be different for someone who has relapsed versus who is maybe primary refractory?
So we include all into this study, and of course we include them knowing that we have a subsequent option. And I do something which is not in the protocol, but I'm allowed to do it. For the young patients, I do rainy day harvest after GDP, and this is tislelizumab, with the expectation that I might need the cells in a third revision. But we haven't needed it so far. I think it's more attractive to avoid the high-dose chemotherapy in the refractory patient, because the point of giving high-dose chemotherapy is a prerequisite in my eyes is that the patient has some degree of chemosensitivity. And of course, you have shown tumor reduction, but I think we agree that this patient essentially is chemorefractory. So chemorefractoriness talks away from high-dose chemotherapy and transplant in my head.
Yeah, so we've kind of just about finished 3 cycles of Nivo ICE. And so the question is now I have the response, but I just thought I will ask. If she has a partial response, will we consider, and the cost is not going to be available to them forever if we put her on checkpoint inhibitors for a long period of time against the cost of auto transplant and high dose therapy, which is not that expensive for us. So keeping that in mind, whether we would like to consider this patient, if she has a partial response, for high dose chemotherapy and an auto transplant, or she has a 10/10 HLA matched. So any thoughts on what transplant should we consider for this patient? And if you ever think of allo transplants for a young Hodgkin's lymphoma upfront if we call this a resistant disease.
I think this is the perfectly suited candidate for an allo transplant. Auto transplant, again, chemorefractoriness, maybe brentuximab refractoriness, we don't know. So I mean, philosophically, allo transplant. How many allo transplants I have done for Hodgkin's lymphoma? 0. For one simple reason, when we discuss the TRM part of allo transplant, then they don't want to go with it. Again, they would Google it, they would find that with Nivo, I've got some response. So there's a very high transplant-related mortality with lymphomas in allo setting. So that's the major deterrent. The TRM is a major deterrent.
So
In case I was to go for allo, probably I'm going to use some radiation-based conditioning here because this patient has not been exposed to radiation. So TLI kind of regime. But in my practice, it has been very difficult to convince a patient for an allo transplant in Hodgkin's lymphoma.
Yeah, those who have failed auto transplants, it's easier to convince them. So we have kind of 11 patients, out of which we have lost 5. But at least the 6 who are not lost to TRM are doing well in the long run. But without doing an auto transplant to take a patient for an allo, it becomes quite difficult knowing the kind of TRM that we have.
I'm going to say something which I say very rarely. I would recommend an allo transplant. And we are down to less than 1 allo transplant of Hodgkin per year in our center because it's so rarely desired or needed. But I must admit that the patients that I've taken to allo transplant based on a response induced by checkpoint inhibition, they've been successful, all of them. Numbers are low, N is less than 5, so don't put anything to it. But the initial fears that prior checkpoint inhibition would be worse, predict a very severe GVHD, I think that has been quenched, first of all. Second, when you look at the EBMT and American database registries and the very, very high treatment-related mortality or transplant-related mortality that we all know and the patients read about, which is up to 30% sometimes, I think we need to remember that they are from the days when we took patients to allotransplant who were very sick and had totally uncontrolled disease. In more recent analyses from the EBMT, TRM is actually down to more like 10%. And I know this is a short-term follow-up, but the most recent updates are actually quite optimistic. And that is because nowadays we have drugs enabling us to induce deep and stable remissions, transplanting the patients at the right time and not when we have the gun pointed at our temples.
Yeah, so the TRM has been something which is giving me nightmares, like I said, and maybe if we do it now for her, it may be different. Most of our other patients have been taken after the 4th line and when they have failed high-dose chemotherapy and an auto transplant. So I will keep this in mind for certain. We did a PET scan after the 3rd cycle and it shows a reasonably good response everywhere with a very little sacral area which still shows some SUVs. So technically this is a partial response. And we have now given her the 4th cycle, still contemplating and debating what transplant to do in this patient. And I think I take back lots of learning from today's presentation here. So thank you very much.
Can I ask you a question?
Sure.
Can she afford a year or 2 of the Nivo? She might just consider one.
No, that is something now at the back of my mind after you mentioned it. Now
But we
I
only
need
do
to
it,
go and discuss
but I
it.
just repeat, we only do it for patients in CR.
Yeah.
Uh,
So we thought we'll give her the 4th cycle, repeat her PET, and if she is in CR, somewhere behind our minds, we haven't given up on auto, honestly, because that is a safe bet. But allo is there in our minds upfront, no doubt about it. And if we look at the costs and at the end of 1 year of checkpoint inhibitors, if we fail, then to do the allo is going to be an impossible task. And if we do it now, we just have the last amount of adequate funding for her. Suppose we do an auto once she's in CR. What would be the maintenance strategy for this patient? We've already given her a year of brentuximab. We have seen the Athera data. Will be extrapolated to her and give her the maintenance with brentuximab. We will consider anything else as maintenance strategy. Or if she's in response and she does well, just observe her at that point of time. Again, anybody can take this.
I will say she had a definitely response with nivolumab, so we should give nivolumab maintenance maybe 1 year or 2 years.
So certainly some kind of maintenance, most likely Nivo or Pembrolizumab, whichever is cost effective for me, but some kind of maintenance certainly.
And if we do an allogenic transplant?
Allogenic, I'm not sure if I'm going to maintain, if she maintains good remission.
Yeah, so this is
No allogenic transplant, auto only.
anything from suggestions from the audience or, not suggestions, but just which way would you like to go?
I think there is one paper in last ASH abstract. They have given actually pembrolizumab maintenance starting from day plus 60. 8 doses of pembrolizumab maintenance and around 34 to 35 patients. Okay. So though it is not approved, we can consider pembrolizumab starting from day plus 60, 8 doses.
Means kind of
Those are progression on PET.
progression. And after 3 months also PET was progressive, but the biopsy, we could not convince that this is. So my question is that suppose if PET is quite convincing that the patient is relapsing with the disease, but I'm not able to prove by doing a biopsy in your case. So based on the PET finding, can we treat this
No,
patient?
that is the question. I thought many people will tell me, why didn't you treat at that point of time? But I had no answer at that point.
So I think
And very difficult when a biopsy comes negative to tell the patient, now I'm going to treat.
No, right
Maybe-
now I have a patient like this. So just a follicular lymphoma treated with 6 cycle of BR. After 6 months of maintenance, it developed LDH of 4,000 with a big bulky renal mass. And radiologists are not willing to do a biopsy because there is big chance of hemorrhage and all those. In this situation, what to do? That's what I'm asking. Whether to
Okay.
treat, wait.
We go to the pet expert, I think, Martin.
But this is a case where PET was not very helpful. So in fact, you and your patient, you would have been in the same place now without PET, but it probably would have been a less complicated journey if you just had CT scans, because then you would have had a nice response midway. You wouldn't have done it after 2 cycles. You would have done it after 3 or 4. You would have had a nice partial structural response maintained after the end of treatment. You would have thought all is good, probably. And then after a while, she would have relapsed. And so long as her general condition is still okay, your chances of getting successfully through second-line treatment towards a cure would have been the same. So I think the learning when it comes to PET here is that in this particular case, it wasn't very helpful.
Yeah, so the learning from the next case and this case was that many of my principles in oncology have failed now with these new drugs coming in. So I'll just, sure. So I'm already in such deep trouble that I'd take a match sibling donor.
Haplo transplant data is better for Hodgkin's. Of
So
late.
with PTCY, especially
It's
post
better for
nivolumab,
Hodgkin's.
would you choose a
You are
haploidentical
going for-
donor or would we go with the match?
So the minute we found her sister to be 10 by 10, we have stopped thinking of a haplo. But if we have enough data, I think, yeah, that is
But
a.
also whether that data is applicable to India. The haplotransplant data for India go to ISPMT data, they are not very bright. So
Sure.
internationally, the Kaplan-Meier curves are similar. We have a gap which has not been bridged for a long time.
Do you consider actually keeping in mind the aggressiveness of the disease actually?
So peri-transplant, if we are going to do an auto transplant, yes, we do give somebody who's in a partial response, we do think in terms of giving peri-transplant radiotherapy, or we do give it in our institute. If we kind of take the opinion from our radiotherapists, whether they want to give it before, take the patient into some kind of a CR and then do the auto transplant, or if they are not very comfortable, we go ahead with the auto transplant and then in the post-transplant period, we give. That we do for patients who are in partial response when we take them after an auto transplant. For allogenic transplant, I think the suggestion of using a TBI-based regimen will be something that we will consider. And then I don't know if the radiologist will actually think of any more radiotherapy, but we will take the receptor. So the next one, which actually defeats my principles even further, is this old lady who presented with classical Hodgkin's lymphoma stage 3B. She had all the possible comorbidities, and she was a very petite and almost a moribund patient who had undergone all these regimens of therapy before. And she had come with a bad chest infection and she was in the ICU as soon as she came. So she's taken in 2019 a PAVG regimen of 5 cycles. She symptomatically improved, but the disease did not go away. In July 2022, she had persistent disease and she was started on ABVD. After 3 cycles, a PET was done, which showed partial response, but further treatment was stopped because it was COVID times. In July 2021, when she relapsed, she was given COPP into 2 cycles. She had persistent disease. And just before coming to us, she had taken Nivo rentuximab for 3 cycles. And her PET was in complete response, but she had come with this very bad infection. And then she became even more moribund and even more, kind of difficult to manage. It took us weeks of physiotherapy to get her off her bed. And then what would be the next treatment for this patient? She has active disease and it is Hodgkin's confirmed again at our center. So what would be your therapy goals in such a patient who is anyway transplant ineligible, is aged and extremely not so much aged, but very fragile with lots of comorbidities and has already received first, second, third line of therapy? Any guesses, any takers? What would you all do?
Considering her frailty and multiple comorbidities, I will prefer for BV Venda based chemotherapy for her.
So bendamustine, brentuximab for her further. Okay.
Single agent brentuximab would be better because of the cytopenia which may come with bendamustine.
Even single agent nivolumab that may be work because it means the main concern with the brentuximab that is neuropathy. And almost everyone develop neuropathy.
Yes. Any thoughts or same?
More or less similar. So I may not necessarily, once she's in remission, I may not necessarily continue chemotherapy with her comorbidity. I may continue with brentuximab or maybe Nivo or maybe Pembro, limited doses of maintenance.
So by the time she got out of it, she had disease again. And it did take us a long time to bring her out of the ICU and eventually make her fit enough to start therapy. So we decided that whatever she had responded to was what we would give. We continued brentuximab Nivo for about a year. With that, the PET scan was in complete metabolic response again. Having given her almost a year of brentuximab, the difficulty in continuing, especially in her physical condition. So we took this decision of giving her Nivo maintenance every 2 weeks. And eventually, after another few months, when we did a scan, which is about 6 to 7 months later, she had active disease again. So this is on Nivo single agent as maintenance. She gets active disease, and no doubt that she has received first lines of therapy earlier. So we had very little of chemotherapy left. And the biopsy again over here now showed Hodgkin's lymphoma. So we actually had to think what is the next best thing to do. So we just put brentuximab back again, and she's now in complete response. We've completed 10 cycles and honestly don't know what to do. So help.
Can I ask you a question? It looks to me as though she owns a gold mine. So what made you go for COP in third line?
Those were treatments given outside of our institute,
Okay.
so I cannot comment. She doesn't own a gold mine. She belongs to one of these public sector undertakings in the country which support the treatment of not only the person who's working there, but also their parents. And she happens to be a parent of one of the reasonably associated.
So
public
would she
sector.
have access to checkpoint inhibition until progression?
She at the moment she is on Nivo, yes.
And she would, in
Yeah.
principle, be able to get it for a
Yes,
very long
yes.
time?
This is one patient where finances is not something that, of course, we have to start thinking of taxpayers' money, which is ours, but that is a separate. But now starting brentuximab again, she's gone into remission. So what do? Withdraw it and continue Nivo, because with only Nivo she relapsed in about 6 months' time. Or continue brentuximab till there is toxicity and we can go no further. Or stop and then wait, give us some drug-free drug holiday. So actually, I think it's time for dinner. Thank you very much.
So,
But these two cases
Martin, I have
actually
one
have
question.
changed the way we thought of Hodgkin's lymphoma for so many years. We knew that if it was a response, you continue same. If it was partial response, you change. And now we find that, we can still continue on these new molecules without worrying about the PET scan too much. And the second is that sometimes we pull away therapies, obviously for the lack of funding. But if funds are available, it appears that you can reuse these treatments again and put the same patient back in quick succession with the same drugs that we have been using. So this has been all very, I would say, eye-opener for me at the end of my career.
So ma'am, before you close, I have two questions for Martin. A 35-year-old male treated with ABVD into 2 remission, AVD into 4 remission. relapses after 7 years. So how do you treat a young Hodgkin's lymphoma who is relapsing after 7 years?
It's a tricky one. 7 years is a long time, but it's not 20 years. So it's probably not long enough for me to go for another round of anthracycline-based first-line style chemotherapy, which is otherwise what I suppose you're looking for. If I should go for regarded as a more or less de novo disease in a patient with no late toxicities of the ABVD, if I were to do that, I'd go for something like Beercop, and I think Brecap would probably be a pretty neat solution. That would be out of a desire to not give a high-dose chemotherapy in transplant. I think what I would do would be a BV-based second-line induction regimen, non-cross resistant with ABVD, and then high-dose chemotherapy without any maintenance afterwards.
So philosophically, are we taking it as a new Hodgkin's lymphoma or we're treating it as relapse Hodgkin's lymphoma? Because
7
our
years.
protocols would take us different paths.
It's tricky because if it's after 20 years, and we see that too, right? We have to regard it as a new disease because what do these cells do for 20 years? I mean, it's like a marmot. It doesn't go to sleep for 20 years. On the other hand, we have actually done some genotyping, also of Hodgkin lymphoma with very late relapses, and they do sometimes represent the same mutational status. And this, there will be more data coming in coming years because we will have access to plasma showing the MRD of the original disease and then also the relapse disease. I wouldn't know, and whether you regard it as the same disease or another disease doesn't necessarily teach you whether the new disease is resistant to the chemo given once. So I'm not sure it's that important.
It's important.
But for a young patient like that, with 7 years in between, I think I would treat as a relapse disease, but with chemosensitivity.
Yeah. So the primary question was, if I was taking it as a new disease, I may just give few cycles of therapy, stop. So far, the Hodgkin's lymphoma guidelines do not differentiate it into relapse, like non-Hodgkin's after 5 years, you take it as a new. But in Hodgkin's, even if somebody is relapsing after 7 or 9 years, the current guideline is not booking duration. So in our countries where the access to these fancy medicines may not be there.
Is it localized? Sorry.
So let us say localized stage 2 versus stage 3. Would it? So the question is around the philosophy. Do I take it as relapse? Since majority of patients will not have access to CPI because of cost, do I take it as a salvage, bring remission, and transplant?
I would treat as a relapse if it were disseminated disease. Were it localized, encompassable by a reasonable radiation field, I would give a more intensive but not necessarily non-cross resistant regimen such as Beercop, DAC, or Brecap preferably, and then I would give a limited number of cycles in radiotherapy. Disseminated disease, I would go for something more traditional second-line treatment, preferably incorporating a novel agent, BV, for example, and then do high-dose beam and transplant.
The second question, the same age female patient, bulky disease, and where we may have concerns about possible radiation-induced second malignancies. So would you have a tendency to avoid radiation and add something else?
Always, I mean, I would always try and avoid radiotherapy, particularly mediastinal radiotherapy in young patients and in females, and males for that matter as well, but particularly females, of course. So that would play in, and the localization of the relapse disease would play a role too. On the other hand, high-dose chemotherapy and transplant is not without its long-term side effects either. Oh, you mean in the first-line setting?
The first setting, like this lady, she was responding nicely, but had a bulky disease.
In the first-line setting, I'll do everything I can to avoid radiotherapy. So the amount of radiotherapy in our center given to young females, and here we're talking about advanced stage disease or early unfavorable disease, is below 5%. With any disease that involves the heart, significant portions of the lung or the breasts, it's closer to 0%.
So I think there'll be many questions. We'll take them during dinner. And thank you very much for your patient hearing, and thank you very much for the answers that I got.
So I think this was true Lymphoma Connect, because I think we were able to address quite a few questions from the audience, and we did get some answers. But I think we have to always remember that there's no one right answer. So it all depends upon the patient clinical situation and what you've done before and what is available next. So I think in terms of Hodgkin's lymphoma, we've come a long way. First line, I think we have now 4 ready options. Fifth is also going to be there soon. ABVD, BVABD, BRICAD, escalated BioCop. And then the fifth one is still not, open. And of course, when it comes to treating patients with relapses, you have a plethora of options in terms of chemotherapy, in terms of immune checkpoint inhibitors, in terms of BV, and of course, the transplant options which were discussed. We did briefly touch upon the MRD and the ctDNA. I think that is also going to be surely coming in. And maybe I've seen some data, it is challenging the PET negativity. So I think keep your eyes, open there as well, because the ctDNA to look at the minimal residual disease may have implications on, subsequent treatment in a patient who is having a complete remission. So I think Hodgkin's lymphoma, as has been said, is true kind of a poster boy for looking at multi-agent therapies, sequential therapies, transplantation, and so on. So we've learned a lot from how we manage Hodgkin's over the years, and I'm sure we are continuing to learn as new therapies evolve. So with this, I thank Dr. Martin for his presentation and discussion, and all the faculty who was here on the dais and all the delegates. So thank you very much. And now it's dinner and cocktails. Thank you.